So we all agree that this is a topic that many students actually don't like. Grab your piece of paper, grab your pen, and let's go. Welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at acute leukemias. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. So before actually going to leukemias, I will give you a background of blood because this will help you understand. When we're talking about leukemias, it will help you understand exactly where they're coming from and why we see certain characteristic features. Remember that blood is going to be a connective tissue that's going to be in fluid form. It's going to be consisting of predominantly two important components. It's going to be consisting of plasma, which pretty much contains plasma proteins, water, electrolytes, complement system proteins, as well as coagulation factors. And the formed elements are going to be red blood cells, which are also known as erythrocytes, white blood cells, which are also known as leukocytes, and platelets, which are also known as thrombocytes or megakaryocytes. Now remember that these formed elements are going to be synthesized by the bone marrow, specifically the red bone marrow. In the red bone marrow, you have a pluripotent hematopoietic stem cell. Remember that a stem cell is a cell that has the ability to give rise to different kinds of cell lineages while it's maintaining its own population. So you have these pluripotent hematopoietic stem cells that are predominantly going to differentiate into two main groups. They're going to differentiate into what is known as a myeloid progenitor cell, and they're going to differentiate into what is known as a lymphoid progenitor cell. The lymphoid progenitor cell is going to be responsible for the synthesis ultimately of T lymphocytes or T cells, B lymphocytes or B cells, as well as NK cells or natural killer cells. The other kinds of cells are going to be synthesized by the myeloid progenitor cell. These include neutrophils, monocytes, megakaryocytes, erythrocytes, eosinophils, and basophils. Here is a schematic to help you visualize everything that I've been talking about. Here you have your multipotent or multipotential hematopoietic stem cell, which is also known as the hematocytoblast, or you can call it as a hemocytoblast. This can divide into predominantly two progenitor cells, a common myeloid progenitor cell or a lymphoid progenitor cell. The lymphoid progenitor cell can give rise to a small lymphocyte or a large granular lymphocyte. The large granular lymphocyte are also known as the natural killer cells. These small lymphocytes are going to give rise to either B cells that can further differentiate into plasma cells that produce antibodies, and T cells. Remember that there are different types of T cells. There are T killer cells, T helper cells, T suppressor cells. Then you have the common myeloid progenitor cell on the other hand, which can give rise to a megakaryocyte, which eventually is going to be forming thrombocytes or platelets, erythrocytes, which are red blood cells, mast cells, and pretty much a myeloblast, which is pretty much going to be giving you the other white blood cells, the basophils, the neutrophils, the eosinophils, the monocytes, which are eventually going to leave the bloodstream and become macrophages. So keep this schematic in your mind because there could be some mutations affecting the myeloid progenitor cell. There could be some mutations that are affecting the lymphoid progenitor cell that are going to be resulting in these leukemias that we're going to be talking about. So when we're talking about a leukemia, this is just simply a malignant condition. Remember that all leukemias are malignant in nature. There is no benign variant. So this is going to be a malignant condition that's going to be involving excessive production of immature or abnormal leukocytes or white blood cells. So it's pretty much going to be a neoplasm that's going to be arising from the hematopoietic cells proliferating in the bone marrow, but it can also spread and disseminate to the peripheral blood. It can spread to the lymph nodes, the spleen, and the liver, so on and so forth. You can also have what is referred to as a lymphoma, which is another malignant condition. Now, the difference between leukemias and lymphomas is that lymphomas are going to be arising primarily in solid tissues. So they're going to be arising from the lymph nodes, but they can, in some phases, which we refer to as a leukemic phase, also spread to the blood and the bone marrow. But primarily, the lymphomas are going to be arising from solid tissues. Leukemias are found in the blood, and the blast cells are also found in the bone marrow. So how then do we classify these leukemias? We can classify them in two ways. Based on their cell origin, remember that they could be of myeloid origin, so you refer to this as myeloid leukemias, or they could be of lymphoid origin, so you refer to these as lymphoid leukemia. We can also further classify the leukemias based on the clinical course of the disease, where we're going to be looking at the percentage of the blast cells or the leukemia cells in the blood or the bone marrow. They could be acute leukemias or they could be chronic leukemias. Now, if we take both of these classification systems and group them together, we have predominantly four main types of leukemias. You have acute myelogenous or myeloid leukemia, which is known as AML, which accounts for 33% of the leukemias. We have the chronic myelogenous or chronic myeloid leukemias or CML, which are accounting for 14%. The acute lymphoblastic leukemias or ALL, which are accounting for 10%, and the chronic lymphocytic or lymphoid leukemias or CLL, which are accounting for 35%. You also have other leukemias which account for roughly about 8%. So these are the predominant four main types that we will talk about. Remember that this is part one of these leukemia videos. We'll talk about acute leukemias in this lecture, and then we'll talk about chronic leukemias in another lecture to finish up the chapter on leukemias. So remember that in this lecture, we're going to be focusing on acute myeloid leukemias and acute lymphoblastic leukemias. So there are some important considerations that I want you to take note of before we actually continue with the lecture. Remember that in acute leukemias, they're going to be predominantly these immature poorly differentiated cells. These are known as blast cells. Whilst in chronic leukemias, the cells are actually much more mature and than they do look like in acute leukemias, and they're going to manifest as leukocytosis, so a high white blood cell count with or without cell cytopenias or drop in other cell lineages, but large majority of people may be asymptomatic. In acute leukemias, they will have symptoms. You can have chronic leukemias with an acute type of presentation. We will cover that when we look at the chronic leukemias. Then, of course, you have something that is referred to as a leukemia reaction, where you have a neutrophil count that's greater than 50,000 cells per microliter of blood. And then, of course, this is not caused by malignant transformation of the hematopoietic stem cell. It's usually due to other cancers or other infections, such as overwhelming sepsis. You may also have myelodysplastic syndrome, which is usually a precursor of acute myeloid leukemia. This is just simply a group of clonal hematopoietic stem cell disorders that are unified by the presence of different mutations on the hematopoietic stem cell. So they're going to be involving this progressive bone marrow failure. There may even be insufficient proportion of blast cells for you to classify it as the person having leukemia. Because remember that for you to say that this person has leukemia, they should have more than 20% of the blast cells in the bone marrow or in the blood. But in this case, they have less than 20% of these blast cells in the bone marrow. So this is not enough to make a diagnosis of acute myeloid leukemia. And remember that 40% or to 60% of these cases actually evolve into acute myeloid leukemia. So what are some of the causes of leukemia? You can group them into genetic causes and environmental causes. Remember that genetics actually predispose an individual to developing certain conditions. There is an increase in incidence if one identical twin actually develops leukemia. There is an increase in incidence of the other twin actually developing leukemia later on. And then, of course, the incidence also increases with individuals with some chromosomal anomalies and some genetic conditions, including things like Down syndrome, which actually increases the risk by 30 times. You also have some other conditions such as Fanconi anemia, Bloom syndrome, ataxia telangiectasia, xeroderma pigmentosa, Lee-Fuhrman syndrome that may predispose an individual to acute myeloid leukemia as well as acute lymphoid or acute lymphoblastic leukemia. Some environmental factors include ionizing radiation, chemicals, as well as viral infections, those that are RNA-based retroviruses. Remember that with ionizing radiation, you're actually going to be having some genetic damage to this hematopoietic precursors, and it may actually predispose an individual to acute lymphoblastic leukemia, acute myelogenous leukemia, chronic myeloid leukemia, but usually chronic lymphoid leukemia or chronic lymphoblastic leukemia is not implicated. And we've seen this with survivors from the Hiroshima and Nagasaki bombing that was there, the explosion of the and the pollution with the nuclear material. And of course, we see this in patients that are receiving radiotherapy. Some chemicals such as benzene, aromatic hydrocarbons, and treatment with certain drugs such as alkylating agents and other chemotherapeutic drugs have been exposed or have been associated with an increase in onset of leukemias, especially with acute myeloid leukemias. Some viral infections such as human T-cell lymphotrophic retrovirus type 1, even type 2, as well as Epstein-Barr virus has been associated with leukemias, especially in acute lymphoblastic leukemias and some aggressive lymphomas. So remember that there are some genetic abnormalities that are happening in leukemias, and these are going to be changing the normal cell function. They're going to be interfering with processes such as control of normal cell proliferation. So it means that the cell will keep dividing and will not control itself. They're also going to be blocking things like differentiation, where the cell will not be able to mature into its mature cell type. And then of course, this means that this cell is going to be maintaining itself, and it will have this unlimited capacity of self-renewal such that it is unable to die. So quote unquote, the cell immortalizes itself. So it doesn't even respond to any signals that tell it to die or to kill itself by the process that we call apoptosis. So this is what the genetic abnormalities are doing that are going to tip this patient into having leukemia. Now, before we go into leukemias, there is this CDs that usually confuse a lot of students, and there's a lot that you have to know. So remember that for you to suspect that someone has a leukemia, they should have greater than 20% of the blast cells in the bone marrow as well as the peripheral smear. So that's already the first step that you really need to know. So that's the first thing when you're investigating. You do, of course, your bone marrow smear. You do your peripheral smear, or bone marrow aspirate rather. So if you realize that they're 20%, the next step is now to determine what kind of a leukemia is it. Is it an acute lymphocytic leukemia? Is it an acute myeloid leukemia? So you do some certain immunological as well as cytochemical tests. So there are two important things that are going to be able to differentiate between the lymphoid stem cells as well as the myeloid stem cells. So there's something that's known as TDT. So TDT is going to be found in the lymphoid stem cells. So if you get TDT positive, it's most likely that this is a lymphoid precursor cell. Then if you have myeloperoxidase positive, then you know that this is a myeloid progenitor cell. If it's negative, that's obviously it's going to be pointing you towards the lymphoid progenitor cell. Then there are other specific markers now that can differentiate between a mature B cell, a pre-B cell, a common B cell, a pre-B cell, and a pre-B cell and a T acute lymphoblastic leukemia. So these are known as cluster of differentiation proteins. These are just markers that are going to be telling you that indeed this cell is mature. They're just proteins that are telling you that this cell is mature, this cell is immature. Of course, do not spend time to memorize this at your level. It's not as important. I will mention the important markers as we go on with this lecture. And then of course we can do some further analysis on these to tell what kind of mutation has happened, whether there's a translocation from one gene to another or a rearrangement of a certain chromosome. Then you will be able to tell the different kinds of genetic abnormalities and the different kinds of leukemias that are associated. So now let's get back to acute leukemias. So remember that you have these immature white blood cells in the bone marrow, you have these immature white blood cells in the peripheral blood. And remember that there are predominantly two types of acute leukemias, which we will focus on in this lecture. You have the acute lymphoblastic, or you can call them the lymphoid leukemias, or the acute myeloblastic, myelogenous, or you can refer to them as myeloid leukemias. Now remember that with the acute myeloid leukemias, they have a median age of about 65 years. So these patients tend to be much older. Of course, it can start off at any age, but the median age of diagnosis is usually very, very higher than it's compared to with acute lymphocytic leukemias. And remember that these can arise just as a new case, so they can arise without any other predisposing condition, or they may arise in the background of myelodysplastic syndromes, or in an individual that previously had chemotherapy, cytotoxic chemotherapy. We tend to call this as secondary myeloid leukemias. These are very, very difficult to treat. Then of course you have the acute lymphoblastic leukemias, which has a lower median age. It presents in much younger children, so especially in children that are less than 5. Remember that this is the most common cause of malignancy in children, and about 35% are actually above the age of 25. And both the acute myeloid and acute lymphoid have a slight predilection to be occurring in males than they do in females. Now, what exactly is the pathogenesis or the pathophysiology of the condition? Remember that here you have this proliferation, you have this genetic abnormality that is going to be resulting in proliferation of immature blast cells. If you have acute lymphocytic leukemia, there's going to be proliferation of lymphocyte progenitor cells. If it's acute myeloid leukemia, there's going to be proliferation of the granulocyte progenitor cells. Remember that this is happening in the bone marrow. So the malignant transformation that occurs usually is going to be affecting the pluripotent stem cell at any level. Sometimes it can actually affect the committed stem cell lines, which have a limited capacity of cell renewal. And in most of the cases that we see, remember that the white blood cells undergoes through certain stages of development, which may involve myeloblasts, promyelocytes, and even lymphoblasts. So if the defect is actually happening beyond the myeloblast or the pre-myelocyte, then that's going to be characteristic, resulting in acute myeloid leukemia. Then if it's beyond the lymphoblast, that's what we see in acute lymphoblastic leukemia. Now, because you have this proliferation of immature cells, there are some implications that are going to be there. Number one, you're going to have these blast cells that are going to be present in the circulation where they're normally not supposed to be. Sometimes you may have these blast cells actually blocking microcirculation, so you refer to that as leukostasis. Then you may get infiltration of the tissues. This is much more common in the acute lymphoblastic leukemias than it is in the acute myeloid leukemias. So you may get infiltration of the lymph nodes, you may get infiltration of the liver, the spleen, the skin, the gum, even viscera, and the CNS, causing enlargement of the lymph nodes, enlargement of the spleen, enlargement of the liver, enlargement of the gums, so on and so forth. Then, of course, in the bone marrow, you have accumulation of these blast cells. So they kind of crowd out the bone marrow, and they're going to be leading to suppression of the normal hematopoiesis process, because the bone marrow will be caught up in making these abnormal blast cells, and of course it will reduce its ability to make the normal cells. And then of course the bone marrow elements are also going to be replaced in the bone marrow, so there's going to be crowded blast cells that are found in the bone marrow. Now, because the bone marrow is not going to be able to synthesize the cells normally as it's supposed to be, what are we expecting to find? We're expecting to see that there's going to be a decrease in white blood cell count. So this may predispose an individual to infections. We are expecting to see a decrease in the red blood cell count. This may point towards an anemia, or this patient will have an anemia. We're also going to be seeing a decrease in the platelets. So this person may have some bleeding tendencies. So these are the three common features that we're going to be seeing in patients with acute leukemias. So now here's a high yield table to show you the different manifestations of acute lymphocytic and acute myeloid leukemias. There is some overlap. That's why I started off with this table before going into the specifics. So there are features that we're going to be seeing of marrow failure. Remember that there is going to be a decrease in red blood cell count resulting in anemia, a decrease in white blood cell count resulting in neutropenia, a decrease in platelet count resulting in thrombocytopenia. So in short, there is a pancytopenia that may be seen. Remember that leukemias are not the only cause of pancytopenia. You should also keep other differentials in mind that we'll list later on. So if someone has anemia, they may be breathless, they may be fatigued, they may have angina, they may have claudication, which is this pain that they often feel in their muscles, especially on exertion. It's very, very common in the calf muscles. They may have signs like pallor and a cardiac murmur. This is seen in both acute lymphocytic and acute myelogenous leukemias. Then with neutropenia, they may get recurrent infections. So they may get fevers, mouth ulcers, septic. You may also find a septic focus. Then of course with thrombocytopenia, they may get bleeding and bruising. So then you may see this petechiae, you may see gum bleeding, you may see fundal hemorrhage. These features are common to both acute lymphocytic as well as acute myelogenous leukemias. Then you may sometimes get a high white blood cell count. So it's not always that you have a low white blood cell count. And how is this so? It's because all the cells that are being made are being released immature into the bloodstream, and they're going to have a nucleus. Now, when you quantify these cells using your hemogram, anything that passes with a nucleus is going to be counted as a white blood cell count. So you may get this high white blood cell count that may cause leukostasis. So this person may have breathlessness, they may have headaches, they may have confusion, they may have visual problems. And then the signs may include hypoxia, pulmonary infiltrates, reduced Glasgow Coma Scale, which is the level of consciousness, retinal vein dilatation, papilloedema, even some fundal hemorrhage. Then of course there is some tissue infiltration, which is very common in acute lymphocytic leukemias, but not so common in acute myeloid leukemias. So you may get infiltration of the bone. It may infiltrate the bone cortex. It may infiltrate the periosteum, leading to bone pains. And of course, this is seen in both conditions. It may infiltrate the gums. This is a key feature of acute myeloid leukemias. It may infiltrate the skin, where you get these violaceous skin deposits. They are violet colored like deposits. Then you see this in acute myeloid leukemias. You may get infiltration of the liver, spleen, which you're going to see hepatosplenomegaly and lymphadenopathy in both cases. You may sometimes get CNS infiltration, which may cause headaches, cranial nerve palsies. This is more common in acute lymphocytic leukemia. It rarely happens in acute myeloid leukemia unless there's systemic relapse of the disease. Then, of course, you also get testis infiltration and mediastinal infiltration, where you get a testicular enlargement or mediastinal mass. That is common in both these cases. Then, of course, there may be some substance release. So you may get DIC, which may cause bleeding and bruising, ecchymosis, even bleeding from IV sites, which is common in acute myeloid leukemias. You may get hyperuricemia, which is a feature of acute gout, or tumor lysis, which results in acute gout or tumor lysis syndrome. Of course, you'll see renal stones, you may see tophi, you may see acute kidney failure. This is often due to the treatment or the high cell turnover that we see in leukemia. So keep this diagram in mind, or keep this table in mind, because it's a very high yield table that would help you pick up these clinical features whenever you get a patient that possibly could have a leukemia. So remember that acute leukemias are going to be subclassified based on the morphology of the cells, based on the immune phenotypic characteristics, based on the cytochemical characteristics. Why is this important? Because it helps us differentiate between acute lymphocytic leukemias and acute myeloid leukemias, because the nature of the disease or the progression of the disease is different. The prognosis of the disease is different. Even the response to treatment is different. So we'll start off by discussing acute lymphoblastic leukemias, then we'll move on to discuss acute myeloid leukemias before we end the lecture. So remember that with acute lymphoblastic leukemia, this is actually the most common pediatric cancer. About 85% of all acute lymphoblastic leukemias are going to occur in children, with 90% of the leukemias occurring in children being this variant or this type. And remember that 75% of the cases are going to be present in children that are below the age of 15, and this actually accounts for the second most common cause of death in children that are less than 15 years worldwide. It can affect adults of all ages, but the peak incidence, you have two main peak incidences, so pretty much between 2 to 5 years, and the second peak is around 50 years. Now remember that the disease manifest as leukemia when you have these neoplastic cells, or the lymphoblasts, that are going to be involved in the blood, that are going to be involved in the bone marrow, and you have greater than 20% of these bone marrow blasts. Or you can refer to it as a lymphoma when you have these blast cells that are going to be infiltrating the extramedullary tissue, things like the liver, the CNS, the spleen, the testes, so on and so forth. So remember that when you are talking about lymphoblasts, these are just simply abnormal white blood cells that are going to be found in the bone marrow, and they can be found in the peripheral blood in patients that have acute lymphoblastic leukemia. What are some of the characteristics of these that are going to enable you to pick them out that, of course, this is a lymphoblastic cell? They have a very small size, so 10 to 15 millimeters, that's smaller than the myeloblast. Then they have a thin rim of dark blue cytoplasm with no granules. They do not have any granules. Then, of course, the nucleus is round, or it can be convoluted and centrally located. It may contain 1 or 2 nucleoli, which are less prominent. Some cases, or in some instances, the nucleus may actually not be central. So furthermore, the acute lymphoblastic leukemias, I hope I haven't lost you at this point. Remember that we started off by dividing the leukemias into acute leukemias, then chronic leukemias. Then the acute leukemias could affect the myeloid progenitor cell, which you call as acute myelogenous leukemia, and they can also affect the acute lymphoid progenitor cell, which we also call the acute lymphoid or acute lymphoblastic leukemias. Then the chronic leukemias can also be chronic myeloid leukemias or chronic lymphoid leukemias. Then we further subdivide the acute leukemias into acute lymphoblastic and acute myelogenous. Then we're now talking about the acute lymphoblastic leukemias, which can further also be subclassified using a morphological classification as well as an immunophenotypic classification. Remember that the lymphocytes are eventually going to be the natural killer cells, the B cells, and the T cells. So you could have a common acute lymphoblastic leukemia, which accounts for 75% of all the acute lymphoblastic leukemias, and of course is going to be derived from a precursor of B cells. You can have a T cell acute lymphoblastic leukemia, which accounts for 20%. So this is common in adolescents. It's also associated with a high white blood cell count. Sometimes it results in infiltration of the anterior mediastinum, where you have this anterior mediastinal mass, and as well as infiltration of the CNS, where you may get features of CNS involvements, things like headaches, cranial nerve palsies, just to mention a few. Then you have the B cell acute lymphoblastic leukemias, which is accounting for 5% of all acute lymphoblastic leukemias, and this may actually present with extramedullary presentation with metabolic abnormality. So this is the immunophenotypic classification. Then you have a morphological classification, which classifies them into L1, L2, L3. L1, you have this homogeneous population of small cells. This is very common in childhood, and these cells have a small nucleolus. L2, you have a more heterogeneous population of large cells, so different kinds of large cells, and it's seen in adults, and of course with one or more prominent nucleoli. Then you have L3, which is common, which accounts for less than 5% of all the cases of acute lymphocytic leukemias. And of course here there are more mature subtypes with large vesicular nuclei with basophilic and sometimes even vacuolated cytoplasm. So the common ALL includes L1 and L2, the T cell ALL, L1 and L2, then of course the B cell ALL just L3, that's why it's not so common. What is the clinical presentation? Remember that the condition may actually be present in the acute leukemic phase with significant marrow involvement or localized disease. So it can affect the mediastinum, forming a mediastinal mass. You refer to that as lymphoblastic lymphoma. Then of course the condition may present only a few days to weeks before the diagnosis, and most common symptoms are due to disruptive hematopoiesis. So the anemia, the thrombocytopenia, and the granulocytopenia, resulting in features of anemia, bleeding disorders or bleeding tendencies, as well as recurrent infections and fevers. So what are some of the clinical features? You may get anemia, so you may get fatigue, weakness, pallor, malaise, dyspnea on exertion, tachycardia, as well as exertional chest pains. You may get thrombocytopenia, where you get this mucosal bleeding, easy bruising, petechia or purpura, epistasis, which is nose bleeding, bleeding gums. Some people may get heavy menstrual periods or heavy menstrual bleeding, hematuria, which is blood in the urine. And of course, the GIT bleeding may be present, but they are uncommon. Then of course, the patient can actually present with spontaneous hemorrhage, which includes intracranial or intra-abdominal hematomas. Then of course, with granulocytopenia or neutropenia, there is a high risk of this individual developing infections. Then they could be of bacterial, fungal, or viral in origin. And of course, the patient may have these high fevers, they may have severe or even recurrent infections, and they are features of organ infiltration. Remember, it can be seen as enlargement in the liver and spleen. With the spleen, a small proportion is actually seen with acute myeloid leukemia, but this is much more common with acute lymphoblastic leukemia. Then of course the lymph nodes is not so common in the acute myeloid leukemias. You may sometimes have bone marrow and periosteal infiltration that's going to be causing bone and joint pains. It's supposed to be pains, not pina. And of course, this is seen and very common in children who have acute lymphoblastic leukemia. You may sometimes get CNS and meningeal infiltration that is commonly going to be resulting in cranial nerve palsies, headaches, visual, even sometimes auditory symptoms, altered level of mental states. You may also get these transient ischemic attacks or stroke. And in addition to this, you may get testicular involvement that is seen in acute lymphocytic leukemia, especially the T variant. So which means that when we are actually managing these patients and we give them treatment, we should also target the treatment to preventing the CNS infiltration, and we should also irradiate the testicles to prevent testicular infiltration or to treat the testicular disease. So here's the image again, just to beat the point home. You may pause the video at this moment to actually revise on these clinical features. So I will not spend much time on this because I have already spent a lot of time in the previous slide. So how do we make a diagnosis of acute lymphoblastic leukemia? So the first thing that's going to be coming is you want to do a full blood count or a complete blood count with a differential. You order for a peripheral smear, you do a bone marrow examination, and of course you order for histochemical studies, cytogenetics, and immunophenotyping. You may also go on to do a coagulation profile to exclude the presence of DIC. So you may see that there is a raised prothrombin time, activated partial thromboplastin time, reduced fibrinogen levels, increased fibrinogen degradation product. So you get a high D-dimer level. Then you may order for some imaging to rule out any infiltration of organs, chest x-rays, CT scan of the head, the chest, and the abdomen. You may also do a CSF examination to rule out any CNS infiltration. Then of course, remember that the diagnosis is often made when you have the blast cells of lymphoid origin that are greater than 20% in the marrow, or they're greater than 20% of the non-erythroid cells when you have the erythroid component being greater than 50%. And of course, if you do not have the bone marrow, you can use this same diagnostic criteria to look at the peripheral smear. Then there are some investigations that you must also do before you actually start treatment, or during the phase of treatment and after treatment. So some biochemistry, urea electrolytes, creatinine, serum urate. You should also check for the renal and liver biochemistry tests. Then of course, do a cardiac function test, do ECGs, do direct tests of the left ventricular function, so in short, an echocardiogram. Then the reason why we do this is because certain drugs that we give in this condition, such as anthracycline, are actually cardiotoxic. They cause dilated cardiomyopathies such as doxorubicin, daunorubicin, all those are cardiotoxic. So we want to actually assess the cardiac function before we start treatment. Then of course, you may order for other things like uric acid levels, phosphate levels, potassium levels, calcium levels, even serum lactate dehydrogenase, because these may be deranged in what is referred to as tumor lysis syndrome, which is often a complication of treatment, or high cell turnover, because the cells are being killed by this chemotherapy that you're giving. They're releasing the substances in the blood. So you're going to be getting features of hyperuricemia, hyperphosphatemia, hyperkalemia, and increased lactate dehydrogenase, but a drop in calcium levels. Then of course, you also may see an elevated serum liver transaminase enzyme, and then of course, hypoglycemia may also be seen. So what exactly are we going to be seeing when we do our full blood count and our peripheral smear? So we may see a low HB, a low platelet count. The white blood cell count is often very high, but occasionally it may be decreased, or it may actually be normal. When you do a peripheral smear, you're going to be seeing these blast cells that are approaching even 90% of the white blood cell count. And remember that your differential diagnosis for pancytopenia, the conditions that you should keep in mind whenever you see a low white blood cell count, a low platelet count, and a low red blood cell count, then you should suspect aplastic anemia, viral infections such as infectious mononucleosis, vitamin B12, or folate deficiency. And remember, we talked of a leukemia reaction, which is a non-malignant condition where you have neutrophil count that's greater than 50,000, but it's not caused by malignant transformation, but it can be due to other conditions, other cancers, or infections. And when you actually look at the cells, these blast cells do not have aura rods. You can think of these kind of like rod-like materials that you see in the cytoplasm. They are scientifically defined as linear azurophilic inclusions in the cytoplasm of blast cells. So you do not have these aura rods that are present in acute myeloid leukemia. You don't see them in acute lymphoid leukemias. So here's what a blast cell looks like. So these are blast cells. So as you can see, the immature blast cells could either be of myeloid, a myeloid cell, which is known as a myeloblast, or a lymphoid cell, which is known as a lymphocyte, a lymphoblast rather. You have the cells that are bigger than the normal counterparts. So they are very, very bigger than the normal counterparts. They have an immature nucleus, as we can see. And of course, open chromatin. The cytoplasm appears often atypical. Rarely, these are going to be seen in normal individuals. If they are present in normal individuals, then this could be a sign that this person could have a leukemia or a chronic disease that is beginning to transform into a leukemia. Things like a myeloproliferative neoplasms or chronic myeloid leukemia with a blast crisis. Then of course, here's how you differentiate between lymphoblasts and myeloblasts. So the cell size of lymphoblasts are going to be smaller. Myeloblasts are going to be larger. The nucleus tends to be rounded and central in the lymphoblast. In the myeloblast, it tends to be irregular and eccentric, more on the side. The nucleoli tends to be 1 or 2 in number, and it's not prominent in lymphoblasts, but it is more than 2 and prominent in myeloblasts. There are no aura rods that are present in lymphoblasts, and they are present in 50% of the myeloblasts. And of course, the cytoplasm is dark blue film, while here it's pale blue and is granular. So that's how you're going to be differentiating between lymphoblast and myeloblasts on your peripheral smear. And of course, you do also a bone marrow examination, which can be done by aspiration and needle biopsy. Then of course, in the bone marrow, you classically see more than 20%, so about 25, sometimes even as high as 95% of the cells being blast cells. And of course, the bone marrow is going to be showing features like increased cellularity, reduced erythropoiesis, reduced megakaryocytes, replacement of the bone marrow with blast cells. Often it can even be 100%. And of course, you should check the cell lineage to confirm whether it's a B lineage cell or a T lineage cell. So this is where you test for those other markers that I showed you earlier on. Now, these are the specific ones that I want you to know for the purpose of your exam. So for the B cells, you want to keep in mind that it's CD10 and CD19, while as to the T cells is pretty much CD3. So here's a bone marrow aspirate that's going to be showing, of course, a particle from the bone marrow with increased cellularity. So remember that the histochemical studies and the cytogenetics and immunophenotyping studies are pretty much going to help us distinguish between the acute lymphoblastic leukemia and acute myelogenous leukemias, as well as other diseases. So the first thing is that it's going to be positive for TDT, which is terminal deoxynucleotide transferase. So these lymphoid cells are positive for TDT. If they do not have TDT, it's most likely that they are myeloid cells. So you already rule out the acute lymphocytic leukemias. Then you check also for other markers, CD3 that may point you towards cells that are of T origin, CD19, CD20, CD22, which may point you to what? B cell origin. You may also do certain tests to check out if there are other abnormalities that are present, such as a translocation from 9 to 22 that's involving the BCR and ABL gene in adults, as well as a translocation involving the 12th and the 21 chromosome, which is a TLE and the RUNX1 gene. That's very, very common in children. And what you really need to note is that this translocation or this overlap, the BCR and ABL acute lymphocytic leukemia actually overlaps genetically with the acute lymphocytic leukemias in which the Philadelphia chromosome is actually positive. Remember that the Philadelphia chromosome is pretty much a reciprocal balanced translocation between chromosome 9 to chromosome 22. So we should also order for some imaging, chest x-ray that may pick up some mediastinal widening that may be pointing you towards T lymphoblastic leukemias. And of course, the CT scan for any CNS symptoms, CT chest, CT abdomen to rule out any mediastinal masses, any lymphadenopathy, or even the presence of hepatosplenomegaly. How do we manage patients that have acute lymphoblastic leukemia? So remember that if leukemias aren't really treated, invariably they will be fatal. And most often, within a few months, the patient may actually deteriorate and die. Though with this judicious palliative care, it may actually extend the patient's life, perhaps even to a few years. And if you're aiming to actually cure the patient, it may or it may not work. If it doesn't work, it means that the patient has failed to respond to therapy. They may actually relapse and go back to the state that they were before they started treatment, or they may develop other complications that are as a result of the treatment. Now, the management of acute lymphoblastic leukemia is going to include systemic chemotherapy, prophylactic CNS chemotherapy, sometimes even CNS irradiation. It's not often done in acute myeloid leukemia. That's one of the big differences. And if you find that there is a positive Philadelphia chromosome, then you can also give tyrosine kinase inhibitors. You also offer some supportive care to manage the anemia, the thrombocytopenia, and the infections. Sometimes we can actually treat these patients with immunotherapy, targeted therapy, stem cell therapy, and even radiotherapy. And remember that the treatment of these newly diagnosed patients with acute lymphocytic leukemia is going to be consisting of about 3 to 4 cycles of chemotherapy blocks of non-cross-resistant chemotherapy for at least 9 to 12 months, and then 2.5 to about 3 years of maintenance chemotherapy. So what are some of the stages of the chemotherapy? So you have remission, induction, you have consolidation of early intensive phase, post-remission consolidation, even maintenance phase, and the CNS system prophylaxis. So predominantly 4 main phases. So in remission, you're going to be given these intensive systemic chemotherapy drugs, and the goal of this is pretty much to reduce the leukemic cells below the level in which you can detect them clinically. So you say that this person has gone into complete remission if this happens. Then, of course, the next phase, which is known as a post-remission consolidation, or you can just refer to it as a consolidation phase, which happens to be after the complete remission. If there's no further treatment given, the leukemia cells can actually expand and can actually lead to relapse, and they can actually happen again. And this phase is the phase where we're going to be giving intensive chemotherapy. Then of course the next phase is the maintenance phase, where you get lower dose chemotherapy that is given over several years. Then of course we say that the hallmark in the difference between the management of acute lymphoblastic leukemias and acute myeloid leukemias is the presence of CNS treatment. So here we give CNS prophylaxis in the phase of local chemotherapy and radiotherapy, which is given to the sites of frequent relapse, like the CNS, even the testes. This, of course, prevents leukemic meningitis or malignant meningitis. And this is done for acute lymphocytic leukemia. It's not done for acute myeloid leukemia. So remember the 4 general phases: remission phase, post-remission consolidation, interim maintenance and intensification, as well as the maintenance phase. And then you also give some chemoprophylaxis. So in the remission induction phase, you're going to combine high-dose corticosteroids such as dexamethasone or prednisolone, and anthracycline such as daunorubicin, doxorubicin, idarubicin, together with vincristine for about 4 weeks. Then of course, the goal is to get this patient into complete remission. Remember, when you have complete remission, you have less than 5% of the blast cells in the bone marrow, an absolute neutrophil count that is greater than 1,000 cells per microliter of blood, or a platelet count that is greater than 100,000 microcells per liter of blood. And then of course, this patient must not need any blood transfusion. Then of course, once this patient has gone into remission, the goal is to prevent the leukemia cells from growing back. So usually this is going to be lasting for a few months, and you combine different regimens of specific courses of non-cross resistant drugs that have different mechanisms. Of course, your local hematologist will know the drug regimen that is recommended for the patient. Then of course, you go into the next phase, which is in the interim maintenance and intensification phase, where there is a combination of 6-mercaptopurine, methotrexate, and a bone marrow transplant that can be done. And then of course, maintenance, which is done with monthly vincristine, weekly methotrexate, daily mercaptopurine, and 5 days per month of corticosteroids. Of course, this therapy is done for about 2.5 years to about 3 years. And remember that CNS prophylaxis, there is a radiation to the whole brain, which is combined with intrathecal methotrexate that can be given via lumbar puncture. This usually starts during the induction phase and continues throughout all the phases of treatment. We can also offer supportive therapy to this patient. So in patients that have severe anemia and thrombocytopenia, especially those that have a platelet count below 20 cells, they have a risk of bleeding. Then you may actually transfuse these patients with whole blood and platelet concentrates. Otherwise, you can give them packed cells, and as well as fresh frozen plasma or cryoprecipitate, depending on whatever you have. Then, of course, infections are very common in patients with acute leukemias. So appropriate preventive measures must actually be put into place, especially for patients that are immunocompromised such as this. So you should isolate the staff and visitors and use face masks. You should practice careful hand washing before coming into contact with the patient. Of course, they should advise the patient to only eat cooked food. Then, of course, when infections do happen, the gram-negative infections are very common. And so these are going to be requiring a very strict evaluation and empirical treatment with antibiotics until you get your culture results. And then you can change your antibiotics to tailor the organism that is causing this infection. What are some of the prognostic factors? Favorable prognostic factors include an age between 3 to 9 years, white blood cell count that's less than 250,000 microliters of blood, cells per microliter, 50,000 cells per microliter in children. And then, of course, a leukemic karyotype of high hyperdiploidy. So it means if someone has chromosomes 51, about 51 to 65 chromosomes, or they have a translocation affecting chromosome 1 and 19, or translocation affecting chromosome 12 and 21. And of course, if there's no CNS disease diagnosis, then all these things are good prognostic factors. Then, of course, unfavorable prognostic factors, if someone has a karyotype of 23 chromosomes, which you call haploidy, or less than 46 chromosomes, which is known as hypodiploidy, or between 65 to 68, that is known as near tetraploidy or triploidy rather. Then if they have translocations affecting these genes and rearrangements affecting these genes, then of course some other translocations affecting 5 and 14, 8 and 14 over here, 8 and 22, 2 and 8, 9 and 22 if they're increased age in adults, and of course if they have BCR and ABL like molecular signature. Of course, this may not be necessarily important for your exams, but it's sometimes good to know as it's the difference between an A plus and an A. Then remember that prognosis, the likelihood of initial remission is about 95% or more in children, and then it's about 70 to 90% in adults. And about more than 80% of children actually have continuous disease-free survival for about 5 years and appear to actually been cured. Then less than 50% have a long-term survival in adults. Now, there are some reasons why children actually benefit more, or the prognosis is better in children than in adults. Some of the factors that have been noted are the less ability to tolerate intensive chemotherapy in adults, and of course there is more severe comorbidities in adults, and of course there's a higher risk of ALL genetics that can confer resistance to chemotherapy in adults, and of course poor adherence to the treatment, because this may include often visits, daily or even weekly visits on the outpatient chemotherapy department, or as well as doctor visits. And of course, there are less frequent use of pediatric-inspired treatment regimens. There are different regimens that are given to adults. So those are the important things that you really need to know about acute lymphoblastic leukemia. Then we'll move now to acute myeloid leukemia. So remember that here you have myeloblast cells, which are abnormal cells that are predominantly making up the acute myeloid leukemias. So these are going to be larger than the lymphoblasts. They're going to have a low nuclear to cytoplasmic ratio, prominent multiple nucleoli, and they'll have this aura rods. These are just simply stick-like structures in the cytoplasm in about 50% of the acute myeloid leukemias. Then of course they have granules in their cytoplasm. Remember this table that was differentiating between the lymphoblast and the myeloblast? You can pause the video to help you recall this information. I won't spend time on this because I already talked about it earlier on. Now remember that with acute myeloid leukemias, just like with lymphoid leukemias, they are actually much more common in men than they are in women, slightly. Then of course they account for about 25% of childhood leukemias that often develop in infancy. But of course the incidence increases with age, and the median age of diagnosis or onset is about 68 years. So they are much older than the patients that we see in acute lymphoid or acute lymphoblastic leukemias. And these cancers can actually occur as secondary cancers after an individual may get chemotherapy or radiotherapy for a different type of cancer. Then they develop acute myeloid leukemia as a complication. And this tends to be very difficult to treat with chemotherapy alone. Now, the FAB group these types of leukemias into 8 predominant subtypes based on 2 things. Based on the degree of differentiation, based on the maturation of the predominant cells towards the granulocytes, monocytes, erythrocytes, or megakaryocytes. So there are about 8 subtypes. And please, I would want you to know these subtypes and the important characteristic features that I'm about to list in the next slide. So you have M0, M1, M2, M3, M4, M5, which is 2 subunits, M6 and M7. So M0 is also known as undifferentiated acute myeloid leukemia. So here you have these primitive cells that do not stain with anything. They don't have any cytochemical stains. Then of course these are going to be accounting for 3% of the acute myeloid leukemias. Then of course you have the acute myeloid leukemia without maturation, which is M1. So here they have a few azurophilic granules, and these are accounting for 20%. Okay. Then the greatest majority, which is accounting for 25% of the acute myeloid leukemias, then these are also known as acute myeloid leukemias with maturation. So you have blasts with promyelocytic granules. The aura rods are present. Then they strongly bind to peroxidase as well as Sudan black. Then of course the are going to be accounted for 25% of the acute myeloid leukemias. M3 are pretty much the promyelocytic leukemias. These are going to be hypergranular promyelocytes, often with aura rods in the cells. Then M4 is the acute myelomonocytic leukemias. If you notice, this is just simply the different phases of the white blood cell differentiation. So these are the monocytoid appearing cells in the peripheral blood. Of course, they have a strong avidity to non-specific esterases, and they account for 20% of the acute myeloid leukemias. Then M5 is the acute monocytic leukemias, which has 2 subtypes, the M5A, which is undifferentiated, the M5B, which is differentiated, and with 80% promyelocytes and monocytes. And then of course both have avidity to non-specific esterases and account for 20% of the acute myeloid leukemias. Then of course M6, you have the acute erythral leukemia, which is just the erythroblasts that are more common in about 50% of all nucleated cells. These ones are going to be binding to periodic acid stain. Then of course they account for 5% of acute myeloid leukemias. Then of course M7 7, which is the acute megakaryocyte leukemias, which you have more megakaryoplasts, about 30% of all nucleated cells. And then, of course, these are going to be accounting for 5% of acute myeloid leukemias, and they have activity to periodic acid sheath. So what are some of the clinical features? Remember that the dominant pattern is going to be bone marrow failure, which is caused by accumulation of these malignant cells. So you have the anemias, you have the thrombocytopenia, and you have the infections. Remember that the thrombocytopenia and the DIC are characteristic of the promyelocytic variants of the acute myeloid leukemias. Then the tumor cells can also infiltrate a variety of tissues. And of importance, you have gum hypertrophy and infiltration, skin involvement, and CNS disease, which are usually a feature of the myelomonocytic and the monocytic subtypes. Those are the ones that I want you to keep in mind. Here's a table again to help you remember the different presentations. This is the most important thing from the clinical features that you should keep in mind. So you may pause the video again, have a look at the table. It's just for emphasis. So the diagnosis is pretty much the same investigations that we ordered for the acute myeloid leukemia, so I won't go through them. Even these investigations are exactly the same features that we saw. The only difference is that here you're going to be seeing the aura rods in the peripheral smear. This is just to help you note the difference between the lymphoblast and the myeloblast. I hope you can pause the video. Then you do the bone marrow examination and you get the cells and you test them for the different markers. Now remember that the myeloid cells are going to be positive for myeloperoxidase, CD13, CD3, CD15, and CD117. Now, when it comes to the management of acute myeloid leukemias, so there is remission induction, which is going to be using daunorubicin, cytosine, arabinoside for 4 weeks, which is called as a 3+7 regimen. Then the continuation or intensification phase is going to be using 2 to 3 intensive cycles of the same drugs above, or high dose of cytosine plus bone marrow transplant for younger patients. And of course, there is no benefit of the CNS prophylaxis because CNS relapse only occurs with systemic relapse or in some variants of the disease. And there is also no benefit of the maintenance phase when you're treating acute myeloid leukemias. You see the main difference between acute lymphocytic leukemias and acute myeloid leukemias. And then, of course, supportive therapy is exactly the same. You treat the anemia, you treat the thrombocytopenias, you treat the infections as appropriate. Some good prognostic factors include de novo disease, a favorable cytogenetic abnormality such as a transfer from the chromosome 15 to 17 or chromosome 8 to 21. And then you may also get these other mutations that have been noted. Then poor prognostic factors include age greater than 60, male gender, secondary disease such as myeloproliferative disorders. Then you have a high white blood cell count, adverse cytogenetics such as a deletion, some deletions, even some abnormal chromosome subtypes, which I won't go into so much detail of. If you're interested in hematology, you can find the details of this lecture in any hematology textbook. What are some of the complications of acute leukemias? They may be iatrogenic complications such as infertility, which is especially common in males, so we advise them to sperm bank in advance. Then, of course, there is some bone marrow failure, tumor lysis syndrome, which is often as a result of the treatment. So we prehydrate the patients and we may give them allopurinol to prevent this. Then, of course, you have some long-term risks of cancers, hypothyroidism, pulmonary fibrosis, heart failure, and in children, short stature and decreased IQ. I really hope that now shed some light and actually gave you the basis to read up more on leukemias, especially the acute type of leukemias. And the next time you're asked about leukemias, you have some functional knowledge, or you'll be able to meet the criteria and actually pick out a leukemia on your theory exams, pick out a leukemia on your OSCE exams, or pick out a leukemia on the wards when you're working. Thank you for listening to this lecture. If you enjoyed, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment. To Zambia and beyond. My name is Dr. Moses Kazevu.